This is Audrey Valentine with the Washington State Department of Healthcare Associated Infections Program. The purpose of this presentation is to educate healthcare facility leadership and staff about Candida auris and that yes, your facility can keep residents safe and healthy during the era of Candida auris. My goal for this presentation is to provide up-to-date information about C. auris, who is at risk, and how to prevent it from spreading. To focus specifically on the key elements of infection prevention that prevent spread of C. auris and most other infectious organisms in nursing homes, and to show how facilities and public health working together can make healthcare safer for all patients. Everything you do to protect residents from C. auris will improve your infection prevention program and protect your residents from other infectious agents. To start off, take a moment to think about what you already know about Candida auris. Some things you may think of include that it's a new fungus or yeast, it spreads easily, it's dangerous to certain patients, and it's resistant to some of the most commonly used hospital disinfectants. These are some of the headlines that you may have seen. Most make C. auris sound pretty scary. Words like deadly fungus, drug resistant, and emerging threat. If you've been paying attention to C. auris, you may know that it has caused large and difficult to control outbreaks in hospitals and nursing homes in some parts of the country. And it is now spreading in Washington healthcare facilities. People can become colonized, but based on what we know so far, we are only seeing dangerous infections in very vulnerable patients who have indwelling medical devices. Candida auris was first identified and named in 2009 when it was isolated in Japan from a patient's ear. Over the next several years, C. auris started causing large healthcare outbreaks in healthcare facilities in the US and in some international locations. Over time, we learned that there were 5 different clades, or families, of C. auris that emerged almost at the same time on different continents. C. auris was introduced to the US, and then it started to spread in certain healthcare facilities. I'm sure you already know a lot about Candida albicans, a common yeast that often causes mild infections like oral thrush. But even though Candida albicans usually causes no or only mild infections, it can cause severe infections in immunocompromised patients. There are many different Candida species in and on our body, and most of them cause no harm. But C. auris is different in many ways. As mentioned, C. auris has caused difficult to control outbreaks in certain patient populations. It usually causes infections in very sick patients, those who require long-term high acuity healthcare and have indwelling medical devices like tracheostomies, urinary catheters, or central lines. This group of patients usually also receives frequent treatment with antibiotics and antifungals, which can allow drug-resistant yeast to flourish. These patients, because of their underlying conditions and indwelling devices, get a lot of hands-on care and usually stay in healthcare facilities for long periods of time, both of which increase opportunities for spread of microorganisms, including C. auris. Based on national surveillance, we believe that C. auris is not a threat to the general public and not to most patients in healthcare. We are concerned about Candida auris because, unlike most other Candida species, Candida auris is resistant to many of the antifungal drugs used to treat it. Patients can become colonized with C. auris. Colonization puts someone at a higher risk of developing an invasive infection due to C. auris. Patients who are colonized or infected with C. auris can spread it to others in healthcare facilities. C. auris can be difficult to identify in the lab because it's new. Some labs don't have the right tools to identify it. For vulnerable patients, such as those with long-term indwelling medical devices, it can cause serious infections. Finally, C. auris persists in the healthcare environment unless special cleaning methods are used. Some of the most commonly used hospital disinfectants may not be effective against C. auris. C. auris spreads in healthcare settings like many other germs, and it's usually due to lapses in infection control practices. It is in skin cells and body fluids, so anything that gets used by or on a patient with C. auris can get contaminated. The most common routes of spread are on shared equipment and surfaces, on caregivers' hands and clothing, and in shared rooms and bathrooms if they are not effectively cleaned and disinfected. This photo shows sites in patient rooms that are most commonly positive for C. auris, including the bed, bed rail, remote control, chair, and bedside table. But also think about other things that a resident might touch, such as the faucet, doorknob, light switch, phone, and toilet handle. All of these can become contaminated. Think about whether your EBS team cleans these places. Do you audit these practices to make sure? Here's a quiz to get you thinking. True or false, Candida auris is very dangerous to healthy people. The answer is false. It's not dangerous to the general public and not to most people in healthcare facilities. C. auris is dangerous to patients with comorbidities and indwelling devices, and usually these people are in high acuity long-term care facilities. Here is a summary of C. auris in Washington through July 2025. The first locally acquired case was reported in July 2023, and the first healthcare outbreak was reported in January 2024. Most of the people who have been identified to have C. auris in Washington have been colonized, not infected. This means that they have it in or on their body, but are not having any symptoms. Most cases have been linked to another known case or outbreak, but we have had several cases with no link to another known case. These unexpected cases make us believe that it is circulating silently in Washington. So that's the bad news. Now, what can we do about it? Our message is everyone needs to strengthen their infection prevention programs. This is a cute vintage graphic that says, "Be prepared, it's not just for scouts." What we are saying is be prepared, it's not just for C. auris. Everything you do to prevent C. auris will also protect your residents, staff, and visitors from other germs as well. Efforts devoted to C. auris prevention will not be wasted. Now we're going to talk about how to prevent C. auris from spreading in your nursing home. To be effective, all of these important infection prevention actions must be supported by your facility leadership with policies and resources to implement, reinforce, and audit. If you detect a case of Candida auris in your facility, you should report it to your local public health department. As of 2023, C. auris is mandated to be reported to public health. The rest of these are all of the usual infection prevention actions you can take to prevent the spread of germs. We're going to go over each one individually, but I'll just list them now. These include patient placement, transmission-based precautions, personal protective equipment, hand hygiene, environmental cleaning and disinfection, reprocessing reusable medical equipment, and performing colonization screening in certain situations. For C. auris, patient placement is important. Ideally, residents with C. auris should have a private room. Second best is to be cohorted with another C. auris patient. If not possible, then the final option is to place someone with C. auris in a shared room with another resident who is at low risk for acquiring the germ. That would be someone who has no indwelling devices or wounds and is mostly independent with ADLs. In this last situation, you can ask your local health department for guidance. C. auris infected and colonized residents should be placed on enhanced barrier precautions at a minimum. C. auris is one of the targeted MDROs for which DSHS and CDC require that homes use EBP. Nursing homes can consider placing C. auris patients on CP or contact precautions until they ensure that they are using all of the right IPC practices, meaning that you are using an effective disinfectant, your staff and EBS team have been educated about the organism, and you're reinforcing and auditing practices before switching to EBP. Remember, public health is your friend. They are ready to help you to know what to do. Please call them for a consult if you're unsure. This is just a review of EBP. EBP are required for residents with certain MDROs such as C. auris, for residents with wounds, and for residents with indwelling devices. Staff should use a gown and gloves in the room for high contact care, but not for things like passing a med or delivering a meal tray. Residents on EBP can still participate in activities outside of their room and in communal dining. As for all residents, they should have clean hands, clothing, equipment, and contained discharge before leaving their room. The links at the bottom of the slide are for pocket cards that staff can carry in their pocket to remind them about how to use EBP, and the other is a guide to using EBP in nursing homes. These are things that you can do to ensure that staff are using PPE when needed. Ideally, there is a transmission-based precaution sign that tells people entering the room what type of PPE to use. Personal protective equipment should be available outside of rooms for caregivers to put on before they enter. This photo shows a nice setup for a PPE cart with the EBP sign where it is very visible to staff and tells them what type of PPE to put on. You can see that hand sanitizer is available to use before putting on the PPE, and the cart is stocked with PPE in the drawers. The cart goes outside the room, and there should be a place for waste disposal inside the room so caregivers can discard the dirty PPE before exiting. Hand hygiene is one of the most important things healthcare providers do to prevent spreading germs. Luckily for us, hand sanitizer works as well as soap and water for most organisms, including C. auris. The exceptions are when your hands are visibly soiled and after providing care to patients with norovirus or C. diff. Hand washing is better. Hand sanitizer should be available in each patient's room and immediately outside of rooms. In shared rooms, it should be available between the beds to make it easy for staff to clean their hands when moving to the next resident. Remember that hands should be cleaned before and after patient care, and always after removing gloves. Environmental cleaning and disinfection for C. auris requires special chemicals. You must choose a cleaner and disinfectant that is registered with the EPA as effective against Candida auris. The EPA has a list of chemicals, List P, that are effective against C. auris, and List K products, which are effective against C. diff, which are also effective against C. auris. Each chemical has a set amount of time that the surface must stay wet for it to do its job. This is called the contact time. This may range anywhere from 30 seconds to 10 minutes. Your staff needs to be trained on when to use certain products and how long the surface needs to remain wet. Finally, you need to audit practices so you know that cleaning is thorough and effective. This slide shows a screenshot from the EPA List P. You can see that this is page 1 of 4, so there's a lot of product listed. But I want to point out the breadth and helpful information provided. You have the EPA registration number that is on the label, the active ingredient, the product brand name, the company that makes it, and the contact time, whether it needs to be diluted or is ready to use, what surfaces it can be used on, and what type of setting it should be used in. You can imagine that it will be easier for your EVS team to have a contact time that is shorter rather than longer, so you may want to pursue a disinfectant with a 1-minute wet time rather than a 10-minute wet time. This is a really nice graphic from the CDC that walks you through how to read a disinfectant label to make sure it's the right chemical for the job. And remember that your local public health department can help identify the right disinfectant. Here's another quiz for you. True or false, any EPA registered hospital disinfectant is effective against C. auris? The answer is false. Not all hospital disinfectants work against C. auris. Check the label or EPA List P for the list of chemicals that have been tested and proven to be effective against C. auris. All medical equipment that is shared between patients must be cleaned and disinfected after use to prevent spreading germs to the next patient. You need to make sure that you are following the equipment manufacturer's instructions for cleaning and disinfecting the medical equipment. As you can see on this photo, it's great that the disinfecting wipes are attached to the mobile vital signs cart so staff can easily clean the equipment. If someone else is responsible for cleaning equipment, make sure that you have a clear process for being able to tell what is clean and ready to use versus what is dirty, so equipment that hasn't been cleaned yet doesn't accidentally get used on another patient. Ideally, CORS patients will have dedicated personal equipment like a stethoscope, BP cuff, and pulse oximeter. These should be stored in the resident room and not in the isolation cart where they could contaminate clean PPE. For shared equipment, you need to be sure that it's getting cleaned between patients. We're talking about all types of equipment that gets used on multiple patients, like a Hoyer lift, the blood glucose monitor, and feeding and IV pumps. We recommend making a chart with all of your equipment, including who is responsible for cleaning it, when it should be cleaned, how often, what product should be used, what is the contact time, and where it's stored when clean. If you ask several people in your facility who cleans what, you might learn that everyone thinks that someone else is doing it, and actually no one is doing it. When a resident is being transferred from one facility to another, it's important to share details that impact infection control with the receiving facility to ensure that they know what to do to prevent this new resident from spreading germs to others. This slide shows a form from the Centers for Disease Control that can be used to make sure you include all of the necessary information. These details include whether the resident is known to be infected or colonized with any multi-drug resistant organisms, if they have any symptoms that might require TBP, like a cough or diarrhea, if they were on TBP at the time of transfer, if they're currently being treated for an infection, and if they're up to date on vaccines that might impact care. This is a resource that we developed to help nursing homes identify any infectious concerns when they are receiving a new resident. Consider training your intake staff to ask these 4 questions about new residents and follow the recommendations. Do they have any symptoms that indicate an infectious condition? Do they have any indwelling devices that increase risk for getting or spreading a germ? Are they on TBP in the facility that they are being transferred from? Are they taking any antibiotics for an infection? Do they have an infection or colonization with an MDRO? Here's another quiz question. How does CORS spread in healthcare settings? On contaminated healthcare surfaces, on healthcare workers' hands and clothing, on inadequately clean shared medical equipment, or all of the above? The answer is D, all of the above. CORS can spread from contaminated healthcare surfaces, from healthcare workers' hands and clothing, and from inadequately cleaned mobile medical equipment. The Washington State Department of Health provides free screening for Candida auris in certain patients. We recommend screening incoming patients or residents who may have had a higher risk of having been exposed to C. auris. We recommend screening residents who had close contact with someone with C. auris, were cared for in an outbreak facility, and those who had an overnight stay in the prior year in a healthcare facility internationally or in a part of the U.S. with a high burden of C. auris cases. You may receive a notification from another healthcare facility or from public health that a resident should be screened for Candida auris. We have slightly different recommendations for hospitals and for ventilator-capable skilled nursing facilities. Your local health department can help you figure out who should be screened and how to do it. The process of collecting the screen is simple. You rub a swab in the axilla and groin on both sides, package it up, fill out the paperwork, and ship to the public health lab. Your local health department can walk you through all of the steps. Learning that you have a resident with C. auris can be stressful, but public health is ready to help. We have a guidance document shown here that walks you through all of the steps to take in order to protect your residents and prevent C. auris from spreading. If this is a newly identified C. auris case, your local public health department will be working with you on the response and investigation to prevent transmission, to educate your staff, and to see if this has spread to others. I want to reassure you that you can safely take care of residents with C. auris. Other nursing homes in Washington have done it, and so can you. In addition to what I've presented so far, keys to success are education, having an on-site assessment of your infection prevention program, and to work with public health. These are the resources that I have mentioned in this presentation. The point that I want to make here is that we all need to work together to prevent C. auris transmission in healthcare facilities. Public health is available to answer questions and provide assistance. If you have any questions, please contact your local health department or email us. And finally, I want to thank you for the care that you provide to your residents, and thank you for watching.